Hello, everyone, and thank you for joining me. The topic of this on-demand presentation is a detailed look at the standards, Part B, the examination and procedures, adult transthoracic. During this presentation, I will review the 2012 standards for adult transthoracic with you and hopefully provide you with a bit of additional information. My name is Beverly Gorman, and I am the Director of Accreditation for the Echocardiography Division of the IAC. Please be sure to use the most current revision of those standards, and they are posted on the website, and they can be accessed from the home page. The most recent revisions are highlighted in yellow. The standards for all IAC divisions, whether it be echo, vascular, nuclear, MR, CT, now share a consistent format so that you can easily navigate through the standards regardless of the modality. The enhanced format will also separate the absolute requirements, or those musts, from the recommendations, the shoulds. So it's going to be very clear what the laboratory is required to do and what are recommendations, things you may want to do in your laboratory. During this presentation, I will only focus on the standards or the requirements. I do, however, strongly encourage you to read through the guidelines, those shoulds, because many times the recommendations do become requirements in the future. Section 1B is adult transthoracic echocardiography testing. First, let's look at the instrumentation standard, and it is just a list of the hardware and software that is required on your echo equipment. M-mode imaging, 2D imaging, which must include harmonic capabilities, spectral display for PW and CW Doppler studies, color flow imaging, a monitor, and it must display the parent institution, the name of the patient, the date and time of the study, and you also have to have an ECG displayed. Range or depth markers must be available on all displays. Capabilities to measure distance between 2 points, an area on a 2D image, blood flow velocities, time intervals, peak and mean gradients from spectral Doppler studies. You have to have at least 2 imaging transducers, one low frequency one, that's the 2 to 2.5 megahertz, and one high frequency, 3.5 megahertz or higher. Or, as most equipment I think has, is a multi-frequency transducer, which includes a range of frequencies to meet the needs of adult echo. You also must have a transducer dedicated to the performance of non-imaging continuous wave Doppler studies available at each site. This is that dedicated CW probe, that PDOF, whatever you want to call it, you have to have one available at each site. An audible output must be present at the time of acquisition, and this just means that your echo equipment has to have sound so you can hear your Doppler. This does not mean that your workstation also has to have sound. We know that many of them don't. So again, it's just sound on your machine so you can hear your Doppler. Machines with some, but not all of the above, can be used for limited or directed echo studies, but if you're going to do a complete study, it has to include all of those capabilities. The annual procedure volume must be sufficient to maintain proficiency in examination performance and interpretation. Here you're going to notice there are no numbers. Okay? It just says that it has to be sufficient to maintain proficiency. So we don't set a number on how many studies that have to be performed. If you want to get an idea of what is recommended, they are listed in the recommendations for you to have a look at, but you'll notice that the standards or the musts don't include a number. Transthoracic echo testing has to be performed for appropriate indications, and you have to verify those the reason or the indication for the studies. There has to be a process in place in the facility for obtaining and recording the indication, and before you perform your study, you have to verify that indication, and if you need any additional information, you have to obtain that information. So if you get an order that is unclear what the reason for the study is, or you feel like you need a little additional information, then go ahead and ask. Transthoracic echo testing is ordered and appropriately scheduled. And the ACC and ASE appropriate use documents pertaining to echo must be available for review in the facility. Do yourself a favor, get very familiar with the appropriate use guidelines. They are available on the ASE website, and there's also a link to that document from our website under, I think, resources. So go ahead, print a copy, post it in the lab, save it to the desktop in the lab, but please have everybody have a look at it, read it, and get familiar with it. Ordering process. The echo order and requisition must clearly indicate the type of study to be performed, the reason for the study, and the clinical question to be answered. Okay, all very straightforward here. You have to know why you're doing the study and what type of study you're to do. The signed, and it can be either electronic or handwritten order, must be present in the medical record of the patient. And definition of the procedure types and protocols, and I'm not going to spend too much time on this because in a few moments we're going to be reviewing all the components of a complete study, so we'll review those in just a few minutes. But a limited study, and that is only performed when the patient has undergone a complete or recent exam and there's no clinical reason to suspect any changes. So that is for things like, a patient with a pericardial effusion and you just want to go back and have a quick look and make sure things haven't changed there. The limited study generally examines a single area of the heart or answers a single clinical question. So that's the difference there. Scheduling. Sufficient time must be allotted for each study according to the procedure type. The performance time allotted for a complete study, that's imaging and Doppler, is 45 to 60 minutes from patient encounter to departure. Okay, that does not mean the clock starts when the patient walks into the lobby and reception area of the hospital or walks in the office and says hello to the receptionist. This is actually laboratory time. The time the patient walks into your echo lab, you introduce yourself and you get it started with preparation and then the examination. So it's 45 to 60 minutes. Yeah, you may need an additional 15 to 30 minutes if the study is complicated. An urgent study must be performed at the next available time period. A stat has to be done as soon as possible, preempting routine studies. And availability for emergencies, there must be qualified personnel and equipment available for urgent or stat studies outside normal working hours in an inpatient facility or where appropriate. So if you're in a hospital or some other inpatient facility, you do have to have qualified personnel and a piece of equipment available for those urgent or stat studies. Examination performance must include proper technique. You have to explain the exam to the patient or the guardian. You have to have the patient's height and weight prior to the examination so that the measurements can be indexed for parameters of body size. Examinations of the heart must examine all cardiac chambers and structures, and the course of the extent of the disease must be documented. And we're going to go over all the components of the exam here in just a minute. Elements of the study performance: proper patient positioning, transducer selection and placement, optimization of equipment and gain settings. Now, we have a really nice on-demand webcast available for you to view. It really makes you think about all of the basic things you can do to optimize your gain settings and your display settings. It's really a nice review because I know everybody in the lab gets busy and those kind of things get put off to the side. You don't always optimize your settings correctly. And I can tell you we've seen many times studies submitted to us for review, and the sonographer has started the study and ended the study and has never optimized the gain, never changed any of the settings, just basically scanned. And, you know, that's not displaying your best work. You need to always remember to optimize those equipment settings. Utilization of appropriate Doppler technique, including proper Doppler alignment and measurement. Again, it's back to the basics. Representative image storage of all images and data. Okay, and I like to point out here that if you image something, let's say you have a technically difficult patient and you try to get a subcostal image and you just can't do it, please do yourself a favor. Go ahead, take an image and label it. You know, it's a nice thing for the physician to see that, okay, the sonographer was there, they attempted it, it was nothing but a snowstorm. You couldn't see it. So we have a saying here in the office that if we don't see it, it didn't happen. Okay, so again, go ahead and document. Timely report generation and communication of results and performance of the 2D MO Doppler exam according to the facility's specific and appropriate protocol that includes all views, imaging planes, and mandated by the standard. And there's also a sample document available for that. Elements of the study include, but are not limited to, definition of endocardium, display of standard on-axis imaging planes, avoid foreshortening, delineation of the details of the valvular anatomy, measurements of the left ventricular dimensions from standard orthogonal imaging planes, optimal recording and evaluation of Doppler flows, which are aligned to the Doppler beam and parallel to flow. Accurate spectral Doppler reading and recording of abnormal Doppler flow signals in multiple views. I think the most often omitted Doppler, well, two of the most often admitted Doppler views are for tricuspid regurgitation. Many times we'll see that the sonographer has really gone after the TR velocity from the apical view only, where, you know, sometimes that parasternal long axis view, when you angle, you can get a really nice Doppler signal from there. So, again, it has to be from multiple views. The other one that we see, and I'm going to talk more about it in a few minutes, is using that dedicated CW probe from multiple views. You just, for an AS patient, you have to use multiple views, not just use your apical view with your imaging probe and then take your dedicated CW probe and put it down at the apex again and get another signal. That just doesn't do it. You don't know how that flow is directed. And you have to adhere to the facility-specific protocol, including sequence, with allowances for additional views. So what this standard means is that basically everybody has to follow the same protocol. Okay. Now, we do certainly understand if you have pathology that you want to take additional views and document, or if you have a very technically difficult patient and some views just aren't available. Again, but in general, everybody in your laboratory has to follow the protocol, including sequence. So that means Bev can't do her studies one way and Joe do his studies another way. Everybody has to follow the protocol. Transthoracic echoes have to be comprehensive and include the standard components. and a protocol must be in place that defines these components, and indications for performance of a complete or limited examination must be included. And there is a nice sample document available if you need help or to get an idea of what a protocol should look like. Or you can use that one and just adapt it to how your studies are done in your laboratory. But make sure it's your laboratory-specific protocol, not one that you've gotten off our website or from the lab down the street, and it's not at all how you do your studies. I'll share a funny story with you. We had an adult application submitted a while back, and the protocol they submitted, again, remember, and it was an adult lab, was for a pediatric transthoracic echo. So, again, make sure it's your laboratory-specific protocol. And these are the standard views from multiple planes, including views of all cardiac structures and selected extracardiac structures. And here, this is the list. You have to view the images of the left ventricle, left atrium, right atrium, aortic valve, pulmonic valve, mitral valve, tricuspid valve, proximal ascending aorta, aortic arch. When indicated, when is it indicated? It's indicated for cases of aortic stenosis, severe AI, rule out dissection, and the list goes on. Now, I wanted to point this out and spend a little bit of extra time on this is because what type of studies do we ask you to submit? Regional wall motion cases or LV cases and aortic stenosis cases. So the reviewers are going to be looking for that aortic arch in those AS cases, inferior vena cava and the pericardium. And a complete study and limited exam we've already talked about, so I'm not going to go over this again. And here are your views. Parasternal long axis view, parasternal short axis view, and it has to be at the level of the aortic valve, left ventricle, basal, and mid-apical views, okay? Make sure that that is also included in your protocol, you know, that nice kind of scan. Right ventricular inflow view, and this is from the anteriorly directed parasternal long axis view. Okay, so just make sure that that's in your studies and also in your protocol. Apical 4-chamber view, apical 2-chamber view, 5-chamber view, apical long axis view, and your subcostal 4-chamber view. Subcostal short axis view when indicated, subcostal IVC hepatic vein view, and suprasternal notch view when indicated, and we just talked about that. That is indicated for AS cases, so, and that's your 2D view. The following 2D or M mode measurements, and again, you see it says 2D or M mode. It is up to your laboratory to decide, you know, whether they want to do M mode or 2D or both or however you want to do it, but it does say 2D or M mode. The LV internal dimension and diastole, the LV internal dimension at end systole, your left ventricular posterior basal free wall thickness at end diastole, ventricular septal thickness at end diastole, your LA dimension, end systole, or your left atrial volume index, okay? So either one is acceptable, whatever your laboratory wants to do, either the measurement or the volume measurement, it's up to your laboratory. Aortic root dimension at end distally, diastole. The following Doppler evaluations, the 4 cardiac valves, forward flow for each valve, any regurgitation shown in at least 2 imaging planes with color Doppler. So make sure you do that. Make sure you turn your color on and get at least 2 views of any regurgitation. Also the use of the non-imaging transducer to assess stenotic valve, valvular regurgitation whenever indicated, and that's again that PEDOF or dedicated CW probe, which we're going to talk a little bit more about in just a minute. Tricuspid regurgitation must be sought with CW Doppler from multiple views for the estimation of that RV systolic pressure. Okay, when you have TR, you have to go after that highest TR velocity from at least 2 views. And I think we just talked about that just a little bit a minute ago. Maybe you want to try from the apex. You want to try from that parasternal long axis view. But again, go after it from at least 2 views. Atrial and ventricular septa, and you have to do color Doppler screening for defects. And yes, this is for adults. It's just a quick color look with your color. Make sure that there's no atrial or septal defects. Your left ventricular outflow tract velocity. This is required on all studies, not just your AS studies. So again, do that left ventricular outflow velocity. Velocity time integrals and hepatic and pulmonary vein flow spectra are optional. And for aortic stenosis, the systolic velocity must be evaluated from multiple transducer positions, from the apex, from the suprasternal and right parasternal. And this must include interrogation from multiple views with that dedicated non-imaging CW probe. Again, PDOF, dedicated CW probe, whatever, non-imaging probe, whatever you want to call it, you have to use it, and you have to use it from multiple views, and you have to get at least one clear envelope on your Doppler signals with using that PDOF. And I think many times, and again, we see this daily, sonographers will use their imaging probe. They'll get a nice, Doppler from the apex, and they call it a day. Okay? Well, you're doing your patient a huge disservice because you have no idea which way that AS jet is going. So what you have to do is go ahead and use that PDOF or dedicated CW probe from multiple positions. So use it from the apex. Use it from the suprasternal notch. Turn your patient, get that right sternal border. But really, you have to use it because you're not doing your patient, you're taking shortcuts. So again, go ahead and be sure to use it. The use of contrast for suboptimal image quality. Okay, contrast is indicated when 2 contiguous segments cannot be visualized in any of the 3 apical views. Poor endocardial border definition, as it provides greater accuracy in determining left ventricular function. Contrast can turn a totally suboptimal, undiagnostic test into just a complete diagnostic, excellent study. So go ahead, use your contrast for those suboptimal studies. Now, from any reason, if your laboratory does not use contrast, you have to have a policy in place for alternative imaging. So if you have a very technically difficult patient and you can't get that good endocardial border definition, you have to have a policy in place on what you're going to do. Are you going to suggest a TEE or some other imaging exam? If contrast is used, of course, you have to have a policy in place for the use of contrast agents. Poor endocardial definition is defined as the inability to detect 2 or more contiguous segments in any of the 3 apical views. So if you're not getting a good look at those walls, go ahead and use your contrast. At the beginning of 2012, Dr. Paul Grayburn and Dr. Michael Main, 2 experts in the use of contrast, presented an on-demand webcast on the use of contrast, and it's the basics. It's really the nuts and bolts of using contrast, from who should start the IV to how you use contrast, the warnings warnings and the safety concerns. I mean, they really did a wonderful job of hitting all the bases with use of contrast. So go ahead and take a few minutes. It's an excellent presentation to view this on-demand webcast. Now, if you have any questions, any concerns, you're not sure what to do, please don't hesitate. If you have a technical question, just pick up the phone, send an email. There are 3 of us stenographers here in the office, and we're happy to answer any question, any technical question that you can come up with. When you put the time that we've been in a lab scanning together, it's well over 60 years. So again, use us. We're a pretty excellent resource, and we are always happy to help you. Thank you for your attention.